Hello, everyone. Welcome to this week's Health for the World Radiology Grand Rounds. Please feel free to introduce yourself and tell us where you are logging in from. It is my pleasure to introduce our guest speaker for this week, Dr. Shabnam Fidvi, and she'll be giving a talk on abdominopelvic oncological emergencies, what a radiologist needs to know. Dr. Fidvi trained in diagnostic radiology at Westchester Medical Center, New York Medical College, and then went on to specialize in cross-sectional imaging at Thomas Jefferson University Hospital. She's currently an assistant professor of radiology at Albert Einstein College of Medicine, and her research interests include oncological imaging. We'll have a Q&A session after the lecture, so please add any questions you may have in the Q&A box, and we'll address them after the talk. And without further ado, Dr. Fidvi, please take it away.
Thank you for the introduction, Abhinav. Good morning, everyone. I'm Shabnam Fidvi, an abdominal imager at Montefiore Medical Center in the Bronx, and thank you for tuning in to Abdominopelvic Oncologic Emergencies. I've tried to make this a case-rich presentation to show you as many examples as I can, and I have a fair amount of material to cover, so let's get started, and I'll take questions at the very end. What constitutes an oncologic emergency in a patient? Any acute, potentially life-threatening event in a cancer patient, either secondary to the direct or indirect effects of their cancer or related to its treatment. This can present at any time during the patient's disease course, or it can actually be the first presentation of the disease. Oncology patients may present to the emergency room due to a variety of causes. These include progression of disease, incidental infection, treatment-related complications, and then non-cancer related conditions. In the emergency room, metabolic and hematologic oncologic emergencies are diagnosed predominantly on the basis of clinical features and laboratory findings, and these are listed on the slide. Imaging actually plays an important role in structural evaluation, and CT in particular is helpful in the evaluation of vessel thrombosis or hemorrhage, organ infiltration and compression, obstruction of either hollow visceral organs or ducts, and treatment-related complications, be they chemotherapy or radiation therapy. This is an overview of select oncological emergencies in patients. These include central nervous system emergencies, which I will not be discussing, thoracic emergencies. I'll touch briefly on severe vena cava syndrome. The focus of this talk really will be abdominal emergencies, and then I'll touch briefly on treatment-related emergencies as well. I refer you to the article in Radiographics from 2013 for a more comprehensive review. For the purpose of this talk, I've divided it into 4 major sections. These include vascular, bowel, infection, and bones. In vascular, I'll talk about intra-abdominal hemorrhage, Hispanic rupture, thrombus, and Svc syndrome. Because of the constraints of time, I won't discuss veno-occlusive disease. In bowel, I'll show you examples of obstruction, both proximal and distal to the ligament of Treitz, examples of bowel ischemia, perforation, and fistula formation. Infection, I'll show you examples of abscess and different forms of itis, and then I'll end with a brief discussion of bones, including cord compression and fractures. So to begin with, intra-abdominal hemorrhage. The risk factors for hemorrhage include hypervascular malignancies, and these are listed predominantly hepatocellular carcinoma, renal cell carcinoma, and melanoma. Also remember that a large tumor size and a peripheral or subcapsular location of the tumor predisposes to hemorrhage. There's various mechanisms of tumor hemorrhage, which are listed below. I want to also draw your attention to the fact that trivial trauma can be a predisposing factor for hemorrhage in tumors such as renal cell carcinoma and gastrointestinal stromal tumor. So in terms of intra-abdominal hemorrhage, non-contrast CT does play an important role. Acute hemoperitoneum manifests as high attenuation ascites on a non-contrast CT. This typically has Hounsfield units of 30 to 45 Hounsfield units. Simple fluid usually will not have Hounsfield units higher than 20. And this is due to high protein content in unclotted extravascular blood. On these axial and coronal images, the green arrows show acute hemoperitoneum. You can also see clotted blood, which has slightly higher Hounsfield units, ranging from 45 to 70 Hounsfield units. And then always look for a sentinel clot, which basically indicates the source of the bleeding and the location of the high attenuation hematoma. This is shown by the red arrows on the axial and coronal images. In this patient, the left adnexal cystic lesion was actually the source of bleeding and the sentinel clot. Once you give contrast on CT, intravenous contrast on CT, you look for active contrast extravasation, both within the tumor and around the tumor. And if you see active bleeding with changes in configuration from arterial to the portal venous phases, the patient goes on to embolization or emergent surgical exploration. This is an example of a patient presenting to our emergency room with acute flank pain. This was a 55-year-old male. The red arrow shows an enhancing exophytic right renal mass, and the green arrow, retroperitoneal hemorrhage originating from the mass, tracking inferiorly along the right psoas muscle. Same patient, coronal and sagittal contrast-enhanced images. Again, the right arrow shows the heterogeneously enhancing exophytic right renal mass, and the green arrows the retroperitoneal hemorrhage tracking inferiorly into the pelvis. There's a couple of trivia. Svc syndrome is spontaneous renal and perirenal hemorrhage, which can occur in up to 1.4% of patients with renal cell carcinoma, and this is typically with the clear cell variant. Also, length triad is a constellation of acute flank pain, shock, and a palpable flank mass. Moving on specifically to hepatocellular carcinoma, which we see a lot of in our practice, the risk factors for hepatocellular rupture, hepatocellular carcinoma rupture include large tumor size, typically more than 5 centimeters, a peripheral or exophytic location of the tumor, if the patient has tumor thrombus, if they have systemic hypertension, and if they've been treated in the past, specifically with TACE or transarterial chemoembolization. This is an example of a patient with an exophytic hepatocellular carcinoma and active contrast extravasation with enhancing tumor thrombus. The axial images in the arterial and portal venous phase, and coronal images also in the arterial and portal venous phase. The green arrows show the enhancing tumor thrombus within the portal vein, and the red arrows show the exophytic hepatocellular carcinoma with active contrast extravasation, which changes configuration slightly on the arterial and portal venous phases, indicating that this patient is actively bleeding. This is another patient for our practice, this time an exophytic hepatocellular carcinoma with a sentinel clot. The axial non-contrast CT depicts the sentinel hemorrhage with the yellow arrow. The axial arterial and portal venous phase images show the exophytic HCC, which is the source of bleeding. And then the green arrow on the axial and sagittal images shows the focus of active contrast extravasation, again changing in configuration from the arterial to the portal venous phases, and again shown on the sagittal phase with bleeding into the peritoneum. This is an example of a splenic rupture from the literature. The axial non-contrast and contrast-enhanced images show a perisplenic hematoma, which is high in density in the non-contrast study. This patient was hemodynamically unstable and went on to angiography, which showed active contrast extravasation denoted by the red arrowhead. Both leukemia and lymphoma can be causes of spontaneous splenic rupture in up to 16% of cases, and lymphoma in the spleen can manifest either as a diffuse and infiltrative form, or can be more focal with mass or a mass, with a mass, single mass or multiple masses, excuse me. A little bit more about intra-abdominal hemorrhage. This is a patient with metastatic pancreatic cancer and a left gastric pseudoaneurysm. The axial contrast-enhanced CT images in the arterial and portal venous phases show hepatic metastatic disease, shown by the yellow arrows. The red arrows on the arterial and portal venous phase show the left gastric pseudoaneurysm, and the green arrow on the portal venous phase shows the patient's primary pancreatic cancer, which is in the pancreatic body, and eroding the adjacent vasculature, resulting in the left gastric pseudoaneurysm. Same patient, coronal image showing the left gastric pseudoaneurysm, again depicted by the red arrow because of the size of the aneurysm. The patient went on to angiography. The red arrow confirms the left gastric pseudoaneurysm, and this was subsequently successfully embolized. This is another patient from our practice. This time he has undergone a Whipple procedure, and he actually has variant arterial anatomy. So he has a common hepatic artery originating from the SMA. Unfortunately for him, developed a fairly large pseudoaneurysm post-surgery. And this is shown by the red arrows on the axial and coronal images. He also has partial rim calcification within the aneurysm. Because of the size of the aneurysm, it was decided that the patient should undergo blue embolization. So the pre-contrast images on the upper panel show that the patient has been embolized. This is glue within the pseudoaneurysm. Some of the embolic material also propagated into the intrahepatic arterial vasculature, shown by the red arrows on the non-contrast image. And unfortunately, this patient, because of compromise of the arterial supply, ended up with a left hepatic lobe infarction. This is shown by the green arrows on the arterial and portal venous phases, and eventually developed abscesses both within the left and right hepatic lobe. Moving on to the next subsection within vascular, sometimes it's difficult to differentiate a tumor thrombus from bland tumor thrombus on imaging, and this table from the British Journal of Radiology gives some useful pointers. Tumor thrombus is typically located within the downstream veins, that is, the veins that are draining the tumor, whereas bland thrombus is typically located within upstream veins, that is, veins which are obstructed by the tumor. Tumor thrombus typically can show direct extension from the tumor, whereas bland thrombus does not. Tumor thrombus expands the lumen and can be nodular or beaded in configuration. In the acute phase, bland thrombus can also expand the lumen, but once treated, it actually narrows or occludes the lumen in the chronic phase. If you treat tumor thrombus with anticoagulation, it persists, whereas bland thrombus usually improves or resolves with anticoagulation. And also important to remember that for tumors that inherently enhance, tumor thrombus will show enhancement on contrast-enhanced CT or MRI, whereas bland thrombus does not. If you use spectral Doppler imaging, you can show pulsar waveforms, which is a pretty specific finding for tumor thrombus. This is not seen with bland thrombus. If you do an FDG PET for tumors that are metabolically active, tumor thrombus will show FDG activity, whereas bland thrombus does not. And then lastly, in the case of MRI, tumor thrombus can show restricted diffusion, whereas bland thrombus does not. I'm now going to show you some examples of bland and tumor thrombus. Again, these are axial images and then a single coronal image. These are in the arterial phase. This is the, these are the arterial phase and the portal venous phase. The red arrows show multifocal hepatocellular carcinoma, shown by the red arrows, and the green arrows on the axial and coronal images show bland non-occlusive thrombus within the proximal SMV, which is extending into the intrahepatic portal vein. This is an example of a patient with a tumor thrombus. This time, the patient has an exophytic HCC and aneurysmal tumor vessel architecture, which is equal prognostic indicator for HCC, shown by the red arrows in the coronal and axial images. And you can see that the green arrows show expansile enhancing thrombus within the intrahepatic portal veins as well as ascites. This is a 65-year-old male who presented with adrenal cortical carcinoma. These are axial and coronal images in the enhanced phase, a more delayed coronal enhanced phase, and then a sagittal image. The patient's primary cancer actually is anterior to the left kidney. On the axial phase, you can see enhancing tumor thrombus extending from the tumor, extending into the left renal vein. The coronal image nicely shows enhancing tumor, expanding the perirenal and intrahepatic IVC, both on the enhanced and the delayed images. And the sagittal image nicely shows that the tumor is actually extrarenal in origin. This is the same patient at this point. This is a follow-up. He's undergone a left adrenalectomy in the interim, and unfortunately for him, still has pretty large expanding enhancing thrombus within the intrahepatic IVC, this time extending into the suprahepatic IVC and the right atrium. And he also has developed a hepatic metastatic focus within segment 7 on this follow-up. Just to touch briefly on Svc syndrome, the two commonest etiologies are lung cancer and lymphoma. Other tumors listed on the slide can also present with Svc syndrome. And CT plays a role in evaluating the Svc syndrome in terms of whether there's direct invasion or compression of the SVC. It can determine the location and the severity of SVC obstruction, and then also identify other associated features such as thrombus, mediastinal or lung masses, lymphadenopathy, and whether there's collateral vessels. For patients with significant SVC obstruction, these usually require treatment either via angioplasty with or without stenting. The chest X-ray image on the upper panel shows an abnormal right paratracheal soft tissue mass shown by the red arrow, and also bilateral pleural effusions. This patient subsequently underwent contrast-enhanced axial and coronal, underwent a contrast-enhanced CT, and the axial and coronal images show a fairly large central lung tumor, and this causes significant attenuation of the SVC and the resultant SVC obstruction, which is denoted by the red arrow. So I talked about the vascular causes of oncologic emergencies. Now moving on to bowel, and what I'm going to discuss is obstruction, either proximal to the ligament of Treitz or distal. Distal can be small or large bowel. Also touch on ischemia, bowel perforation, and then fistula formation. So within bowel, the first important emergency is ischemia. Almost 7% of patients with colorectal cancer can present with coexistent ischemic colitis. A high-grade mechanical obstruction can cause severe colonic distension with resultant ischemia. You can also have bacterial proliferation and stagnant bowel contents resulting in ischemia. And also remember that patients with pancreatic cancer or other malignancies that involve the root of the mesentery can cause small bowel ischemia. This is due to either involvement of the superior mesenteric artery or the superior mesenteric vein. On CT, You want to be mindful of features of ischemia, which include pneumotosis, gas within the wall of the bowel, portovenous gas, and very importantly, always remember to look for the degree of bowel wall enhancement, which can be a sign of impending ischemia and perforation. CT also can help you to evaluate the primary cancer and the status of the mesenteric vessels. This is a relatively recent example of a patient from our practice. She's 62 years old and presented to the ER with abdominal pain. These are axial and coronal contrast enhanced images. The blue arrow shows bland appearing thrombus within the more proximal SMV. The yellow arrow shows enhancing thrombus expanding the lumen of the SVC below this. She incidentally had a large solid and cystic mass within the abdomen and pelvis, which was thought to represent an inherent cancer shown by the red arrow. And what I'd like you to pay attention to is that the jejunal small bowel loops within the left flank actually show hypoenhancing bowel wall, which is suspicious for ischemia. Same patient, coronal images sequentially through the abdomen. Again, the red arrows showing the patient's primary ovarian cancer. The yellow arrows nicely depict the branching, enhancing xenothrombus within the superior mesenteric vein and extending into the venous tributaries. The blue arrow shows bland thrombus higher up within the SMV, extending into the portal vein. And again, the green arrows show the hypoenhancing bowel wall. As the mucosal enhancement is preserved, but it's actually the muscularis layer that is non-enhancing, which is suspicious for bowel ischemia. The same patient was not doing well and had a follow-up CT 2 days later, which shows progression of ischemic changes. You'll note now that there's more extensive hypoenhancement of the bowel wall shown by the green arrows, now involving both jejunal and ileal small bowel loops. So she has worsening diffuse bowel ischemia. Again, the red arrows show the patient's primary ovarian malignancy. She also has ascites. Oncological emergencies can also present with bowel obstruction due to intussusception. Almost 50% of cases of bowel intussusception can be due to malignancies. One of the important malignancies to keep in mind is lymphoma, and other neoplasms that can be a cause of intussusception are gastrointestinal stromal tumors and metastases such as melanoma and breast. So this is actually a patient that I saw on call. She was a 41-year-old female that presented to the emergency room with acute abdominal pain. This is a scout CT topogram that's obtained prior to the CT. And you'll notice that there's a relative paucity of bile gas within the right abdomen as compared to the left. The patient goes on to have a contrast-enhanced CT. These are axial contrast-enhanced images. And you'll see a fairly large ileocolic intussusception extending to the level of the mid-transverse colon on these images. It's also very important to evaluate the mesentery when looking at an abdominal CT, because she has fairly significant mesenteric neural disease depicted by the red arrows. These are images through the lower abdomen, which again show extensive metastatic neural disease from lymphoma, shown by the red arrows, and then abnormally thickened small bowel loops due to lymphoma disinvolvement. Because of the patient's condition, she was taken to surgery. She underwent a hemiplectomy, and lymphoma was found to be the cause of the ileocolic intussusception. She was also incidentally diagnosed with HIV at the time of her ER presentation. This is the same patient with coronal images, again showing bulky mesenteric lymphadenopathy due to the patient's lymphoma. And the yellow arrow also shows a small focus of lymphoma within the spleen. Now to discuss bowel obstruction. CT plays a really important role in determining the site of bowel obstruction, chiefly whether this is proximal to the ligament of Treitz or whether it's distal to the ligament of Treitz, involving both small and large bowel. It's also important to assess the severity and the etiology of obstruction. It's important to the surgeons to know whether the obstruction is proximal or distal. This is because obstructions proximal to the ligament of Treitz are predominantly treated with endoscopic management, and these are malignant gastroduodenal. This is malignant gastroduodenal obstruction, either due to gastric, pancreatic, or duodenal groove, or gallbladder cancers. I'm going to show you a couple of examples. So these are axial and coronal contrast-enhanced CT images of a patient with pancreatic cancer and the gastric outlet obstruction. The yellow arrows show significant intrahepatic biliary ductal dilatation due to the patient's pancreatic head mass obstructing the biliary tree. This is denoted by the red arrows on the axial and coronal images. And then the green arrow shows the level of the gastric outlet obstruction due to contiguous invasion by the pancreatic cancer. You will see on the axial and coronal images that the stomach is significantly distended with fluid, which is a sign of a gastric outlet obstruction. This is a different patient, this time 78-year-old, and he has a right colonic cancer, which is shown by the red arrow on this image. Because of its proximity to the duodenum, this tumor invades the duodenum, shown by the green arrows, and causes a duodenal obstruction. The patient, as a consequence, has significant gastric distension, shown by the yellow arrows. You also note that there's gas within the wall of the stomach, which is gastric pneumatosis and a sign of gastric neural ischemia. And then the other yellow arrows within the central liver show portal venous air. Same patient showing malignant gastroduodenal obstruction. Again, the patient's primary right colon cancer is shown by the red arrows. This contiguously invades the duodenum, depicted by the green arrows, causing a duodenal obstruction. And subsequently, there's significant gastric distension with fluid, gas within the wall of the stomach, indicating gastric neural ischemia, the so-called gastric pneumatosis, and portal venous gas. Moving on more distally within the bowel, obstructions distal to the ligament of Treitz can be treated with a variety of options. These include surgery, endoscopic intervention, pharmacologic palliation, or in patients with inoperable disease, self-expanding metallic stents. I'm going to show you examples of both malignant small bowel obstruction and malignant large bowel obstruction. First, to discuss small bowel obstruction. This can be due to serosal metastatic disease, such as in patients with melanoma, breast cancer, and lung cancer, or it can be due to a more diffuse form of peritoneal carcinomatosis. What we see on CT, you usually see dilated small bowel loops with either single or multiple transition points, and then tumor within the small bowel can manifest as enhancing intraluminal, neural, or serosal tumor deficits. You can see asymmetric neural thickening involving bowel. Diffuse peritoneal carcinomatosis usually manifests with nodular peritoneal thickening and bulky peritoneal masses. This is an example of a patient with endometrial cancer. The axial CT images show hepatic metastatic disease, outlined by the yellow arrows. On the lower image, the yellow arrows show carcinomatosis, both within the right abdomen and within the anterior abdominal wall. And you will see that the green arrows depict proximal dilated small bowel loops. If you follow the small bowel down into the pelvis, there's a caliber change denoted by the red arrow, which shows a transition point with abnormal mural thickening and enhancement involving the pelvic small bowel. And this is a malignant small bowel obstruction due to serosal metastatic disease. This is the same patient with contrast-enhanced axial and sagittal images. Again, the green arrows show proximal small bowel dilatation. The red arrows, the caliber change with mural thickening and enhancement involving the more distal small bowel. And again, this is a malignant small bowel obstruction in this patient due to serosal metastatic disease. Now to discuss malignant large bowel obstruction. This can occur due to advanced colorectal cancer or gynecological cancers. Stage 4 colon cancer, typically if they're proximal, if they're high grade, if they are node positive, and if they're a mucinous etiology, can have an 8% incidence of the malignant large bowel obstruction. I also want to point out that sigmoid colon cancers can be relatively small, but they also have a predisposition to malignant large bowel obstruction. And this is due to the typical annular pattern of the cancers, which cause significant luminal narrowing. The sigmoid colon itself has a narrower lumen compared to the rest of the colon and relatively solid fecal content. On CT, you look for an irregular enhancing polypoid colonic tumor. You look for adjacent lymphadenopathy and, more importantly, upstream bowel dilatation. A relatively young male, 56 years old, presenting to our emergency room with acute abdominal pain. In this case, the axial, coronal, and sagittal images show the obstructing cancer at the level of the distal transverse colon, shown by the red arrows. He has significant dilatation of the colon proximal to this, which is fluid-filled, therefore consistent with a malignant large bowel obstruction. And the yellow arrows show that he also has hepatic metastatic disease at the time of presentation. This is an older patient, also with a malignant large bowel obstruction. The red arrows on the axial image show a relatively smaller sigmoid annular cancer, but this causes a significant degree of upstream colonic dilatation. You can see that the colon upstream of this lesion is fluid-filled and dilated, shown by the green arrows, and this is a malignant colonic obstruction due to a sigmoid annular cancer. Same patient with contrast-enhanced coronal and then sagittal images, showing the relatively small focal sigmoid annular cancer, shown by the red arrows, and then significant upstream colonic dilatation with a fluid-filled colon, consistent with a malignant large bowel obstruction. This is a more unusual case of a malignant large bowel obstruction that I came across through the ER. These are axial contrast-enhanced images. The patient had no significant medical history, but presented with abdominal pain. The red arrow on the axial CT image shows mass-like thickening involving the distal stomach that was suspicious for a primary gastric malignancy. You'll see on this axial image that there's a fair amount of infiltration of the adjacent perigastric fat, consistent with perigastric carcinomatosis. And then the axial images also showed that the transverse colon in the vicinity of the patient's primary mass shows an abrupt caliber change at the level of the mid-transverse colon. That's shown by the yellow arrows. There's abnormal mural enhancement and thickening. And this patient basically had a transverse colonic obstruction due to serosal metastatic disease from an adjacent gastric cancer. This is the same patient, coronal contrast-enhanced images from the same study, again showing the primary gastric cancer shown by the red arrows. the perigastric carcinomatosis, shown by the green arrows, and the carcinomatosis extends to the wall of the adjacent transverse colon, where there's a caliber change with abnormal wall enhancement, shown by the yellow arrow. Again, this is the patient with serosal metastatic disease causing a malignant large bowel obstruction, the primary being gastric cancer. You can see that the upstream colon, predominantly the right colon, is significantly distended with fecal content, and there's dilated fecalized or parenchymal lumen as well. Same patient, another coronal image and also sagittal images. Again, the red arrow showing the primary cancer within the distal stomach, the green arrow, the perigastric carcinomatosis, and the yellow arrow, the malignant large bowel obstruction at the level of the mid-transverse colon due to serosal metastatic disease. I'm just going to talk briefly about treatment-related complications. One of these is small bowel radiation enteritis. This can typically occur up to 1 year post-radiation therapy, and it usually involves pelvic bowel because these are predominantly malignancies that involve the rectum, the anus, gynecological structures, or the prostate. Radiation causes adhesive and fibrotic changes in the mesentery with luminal narrowing in strictures, and can also cause bowel dysmotility. On CT, an important history is crucial. You also see luminal narrowing with neural thickening involving the pelvic bowel, and the bowel wall appears angular due to adhesions and associated mesenteric retraction from fibrosis. These are examples from the literature of patients with small bowel radiation enteritis. These two images are contrast-enhanced axial and coronal images showing a patient with cervical cancer treated with radiation therapy. You will see that there's some thickening and neural enhancement involving ileal small bowel loops with a target sign, and there's also an area of luminal narrowing consistent with the radiation stricture. The other image is a more ominous case of a patient who developed perforation and after having a small bowel radiation enteritis, also a case of cervical cancer treated with radiation. You'll see that the pelvic bowel is thickened. She has ascites, and then also these multiple pockets of mottled free gas within the pelvis consistent with perforation. This is a good schematic of immune-related adverse events, so-called IREEs, related to the vast number of immunotherapy agents that are now available to treat oncology patients. This is a little bit beyond the scope of this talk, but I refer you to this article from Abdominal Radiology, which provides a pretty good review. I'll be discussing specifically colitis and pneumatosis intestinalis. This is a chart from radiographics in 2015 showing adverse events, effects associated with the various forms of therapy, and you'll see that there's some repeat offenders which can cause multiple adverse effects. Common among these are bevacizumab, which is used to treat metastatic colorectal cancer, and also some epithelial ovarian cancers, and then TKIs or tyrosine kinase inhibitors, which pretty much seem to be on the list to cause a variety of complications. And again, I encourage you to read this article from Radiographics in 2015 for a more comprehensive review. In everyday practice, if a patient is on immunotherapy, in particular if they are on immune checkpoint inhibitors or ICIs, they can develop colitis. On CT, it's important to differentiate two forms of colitis because both of these are treated differently. The more common form of colitis is a diffuse colitis, which can affect 75% of patients. The less common form is what is called segmental colitis associated with diverticulosis, a SCAD, a CAD, and this occurs in about 25% of patients. So these are different clinical manifestations and CT presentations. Patients with diffuse colitis present with profuse watery diarrhea. On CT, you can see mild diffuse colonic wall thickening with fluid-filled distended colon and mesenteric vascular engorgement. And these patients are typically treated with steroids. In contrast, SCAD can typically shows a greater degree of wall thickening. So in this example of the literature, the white arrow shows significant mural thickening involving the sigmoid colon. The arrowheads show pericolonic fat stranding, and this occurs in a segment of pre-existent diverticulosis. So differentiating the two is important because SCAD is typically treated with both steroids and antibiotics. And these are examples from the literature. This is a patient with diffuse colitis who had metastatic melanoma and was on ipilimumab. And this is a patient with metastatic melanoma, also on ipilimumab, who developed SCAD. This is a patient from our practice with metastatic colorectal cancer who was on cetuximab. The patient was actually just presenting for routine follow-up evaluation for the status of his cancer. The first axial image shows that the rectal surgical anastomosis, and this patient has undergone a low anterior resection. And the green arrows on the axial images and then the coronal image reformatted in lung windows shows that the patient had pretty extensive pneumatosis involving the small bowel. But on perusing his scan, he didn't actually have any features of ischemia, namely bowel wall thickening or bone venous gas. So I ended up calling the referring oncologist. He contacted the patient. He was apparently asymptomatic. So it was elected that the patient just get a routine follow-up, and on a subsequent scan, the pneumatosis had decreased in volume and subsequently resolved. In evaluating for bowel perforations, the location of the perforation is actually key to management. So perforation can occur both with colorectal cancers and GI lymphomas. And it's important to differentiate intraperitoneal from extraperitoneal perforation because these are managed differently. On CT, if you have intraperitoneal perforation, you see typically immunoperitoneum. If it's because of tumor necrosis, this can be small in volume. If the patient has a mechanical obstruction, this tends to be larger in the volume, and the patients usually will be treated surgically. In contrast, extraperitoneal perforation, on CT, you'll see only retroperitoneal gas, and if the patient is stable, they usually manage conservatively, either with drains by interventional radiology or endoscopic or transrectal drains by the gastroenterology service. So this is an older patient that presented to our emergency room with right-sided abdominal pain. These are axial contrast enhanced CT images. You'll see that the red arrow shows a relatively low density mass, which is inseparable from the right colon. The green arrow showed that this low density mass actually invades the overlying abdominal wall and extends into the subcutaneous fat. And the posterior yellow arrow shows that there's contiguous involvement of serous muscle as well. So this was a patient with mucinous colon cancer. Same patient, coronal images from the study, the red arrow again showing the low density mucinous cancer, which invades the abdominal wall, extending into the adjacent subcutaneous fat, and then the yellow arrow showing contiguous serous involvement. This patient also had an MRI, and I showed these axial and coronal T2-weighted MR images to show you how T2 hyperintense the patient's right colonic malignancy is. This is depicted by the red arrows, and that's a typical feature for mucinous cancers involving the GI tract. And the MR also shows contiguous invasion of the abdominal wall musculature on the prone images. Moving on to bowel fistulae, there's different forms of fistulous communication. And really the type of fistulous communication dictates management. The different types are listed in highlighted in orange, and these can occur in patients with cervical, ovarian, and colon cancers. The patients can be asymptomatic or present with pain, nausea, and vomiting, and it can lead to a variety of complications. So, how fistulae managed? The first thing is you stop the offending treatment, start antibiotics, and then decide on a course of intervention. Depending on the fistulous communication, if there's a fistulae to vasculature with symptoms, this constitutes a surgical emergency. If there's a tumor with fistula to the GU structures, namely the urinary bladder, the kidneys, or the ureters, these are considered a high infectious risk and also usually go to surgery. Tumors with fistulous communication between bowel, usually not emergent, entero and tract fistulae. And if there's enteroatmospheric or enterocutaneous fistulae, these are also usually not emergent and can be treated with wound care. So this is an example of a relatively younger patient with metastatic rectal cancer. The axial contrast-enhanced CT image shows metastatic liver disease, shown by the green arrows. And then the axial and sagittal contrast-enhanced images from the same patient showed the patient's primary rectal cancer, denoted by the red arrow, and then the fistulous communication between the tumor and the adjacent small bowel, shown by the yellow arrows. This is a different patient, this time cervical cancer with a history of radiation therapy. And these are axial and sagittal contrast-enhanced CT images, which show a rectal-vaginal fistulous communication. You see that instilled rectal contrast by a rectal tube communicates with and outlines the vaginal calf consistent with the rectal-vaginal fistula. Sorry. Different patient, this time rectal cancer with a rectal-vaginal fistula. The axial CT images show the patient's fairly bulky primary rectal cancer, shown by the green arrow. The red arrows show the fistulous communication with the vaginal cuff, both on the axial and the sagittal images. And you can nicely see that the sagittal image shows the fistulous tract containing gas and a small amount of fluid. And as a result of communication with the rectal lumen, you also see some fluid and gas within the endometrial cavity. This just happened to be an incidental submucosal myoma. Another patient also with cervical cancer, this time both with rectovaginal and vesicovaginal fistulae. The axial and sagittal images show the rectovaginal fistula depicted by the red arrow, and the green arrow shows the vesicovaginal fistula with gas in the urinary bladder lumen as well. The same patient also had left pyelonephritis, axial images through the upper abdomen. You'll see that there's relative hypoenhancement within the left kidney with this kind of strided appearance that was suspicious for pyelonephritis and was subsequently proved on a UA. So just to summarize some of the points that I've discussed in bowel emergencies, always evaluate for the etiology of the underlying bowel obstruction, including the site, determine whether it's intrinsic, extrinsic, and whether it's due to surgery. As in any other case, look for features like internal hernia or closed loop obstruction, the Waldstein, the USC loop configuration. I didn't really discuss any of those. Remember always to evaluate for decreased focal bowel wall enhancement, which is a harbinger for subsequent ischemia and perforation, like the case of metastatic ovarian cancer that I showed you. Remember, you have to tell your surgeon whether the perforation is intraperitoneal or extraperitoneal, because these are managed differently. Intraperitoneal is surgical versus extraperitoneal, which is usually conservative management. And then the type of fistulous communication dictates how the patients will be managed, namely fistulous communications to vessels and the GU system are usually going to be treated emergently with surgery, and the others can be managed conservatively. And I also showed you some examples of treatment-related complications like radiation enteritis and anti-angiogenesis therapy-related complications. Moving on to the next subset of discussion, which is infection, and I'll show you some examples. This is the different kinds of, this slide depicts the different scenarios of infection that can complicate patients with tumors. I'm going to show you examples of enterovaginal fistulae. I've already shown you some in the past, Intra, and then perforating colonic neoplasms, as well as abscesses within the liver due to malignant biliary obstruction. Also, bladder outlet obstruction and hydroureteral nephrosis can result in urinary complications and infection. So these are ultrasound images, sagittal and transverse of an older patient with uterine distension. The red arrow shows significant distension of the endometrial canal, and this is due to obstruction at the level of the internal os. The green arrow shows some solid appearing tissue at the level of the low uterine segment, which corresponds with the patient's cervical cancer. This is a transvaginal color Doppler image of the same patient, which basically shows the endometrial canal is distended with low level of internal echoes consistent with debris. And this patient had pyometra as a consequence of her cervical stenosis. Same patient, axial and sagittal images, again showing a pretty enlarged uterus for the patient's age. The uterine fundus extends above the level of the umbilicus. There's myometrial thinning, and you see that the endometrial canal is distended with what we know is debris and pus based on the ultrasound, and this is due to an obstructing cervical cancer with resultant cervical stenosis. This was a 76-year-old female who presented to our emergency room with abdominal pain. This was a non-contrast study, which basically showed gas within the gallbladder lumen. So that's nicely depicted by the red arrows on the axial and sagittal images. There was also a focal area of discontinuity of the gallbladder wall, which is suspicious for a focal perforation. The green arrow also shows that an astute radiologist, not me, was noticed that there was incidental pancreatic ductal dilatation. So this patient went on to have a contrast-enhanced MRI. The pancreatic ductal dilatation is confirmed by the green arrow and the axial T2 weighted image. The red arrow shows the inflamed gallbladder with an adjacent peripolycystic collection. And this time the patient did receive contrast, so the yellow arrow confirms a hypodense pancreatic mass on the T1 weighted fat suppressed images, which restricts diffusion. And the MRCP images show nicely the double duct sign, a dilated biliary tree and pancreatic duct due to an obstructing mass at the level of the pancreatic head. This patient subsequently underwent contrast-enhanced CT. In the interim, she had a cholecystostomy tube to manage her gallbladder infection. That's denoted by the red arrow. She also had a biliary stent placed. In this case, the yellow arrow showed the pancreatic head mass, which was the cause of obstruction. And unfortunately, at the time of the CT, she also developed She's already developed room-enhancing fluid and gas-containing lesions within the lymphatic lobe consistent with intrahepatic abscesses. This was a relatively young patient, a 36-year-old who presented through the emergency room when I was on call, and she turns out to have a colon cancer involving the splenic flexure, which is shown by the red arrows on the axial and coronal images. Her colon cancer is locally invasive. You can see that there's contiguous invasion of the spleen, denoted by the yellow arrows. And then it also basically invades the left kidney. You can see fluid and gas extending into the anterior left renal parenchyma. The patient was febrile and suspected left bowel nephritis, which was subsequently confirmed on UA. Same patient with axial and with coronal and sagittal images this time. Again, the red arrow showing the fairly large lobulated splenic flexure colonic mass, and the green arrow showing contiguous invasion of the left kidney with fluid and gas consistent with left bowel nephritis and possibly developing lymphorenal abscess. I'm now going to move on to the final section of my talk, which I touched briefly on bony involvement in oncologic patients. This is something to be really aware of because it can constitute a medical emergency. Malignant spinal cord compression can occur in up to 5 to 10% of oncology patients. The incidence is higher in the thoracic spine as compared to the lumbar spine, as compared to the cervical spine. Cancers that can cause malignant cord compression include metastatic breast, lung, and prostate cancer. And bony involvement can be either due to hematogenous spread or contiguous spinal tumor spread. And while MRI with or without gadolinium is the gold standard for diagnosis, a contrast-enhanced CT is actually pretty sensitive and specific both for confirmation or exclusion of malignant spinal cord compression. So like I said, it's really important to pay attention to these patients because they need to be treated emergently, either with radiation therapy or emergent surgical decompression. And I show you an example of a case from our practice. This was a patient, just a routine follow-up CT on our reading list. In this case, someone with hepatocellular carcinoma who had previously undergone a partial hepatectomy and was being routinely surveyed. You can see these axial contrast enhanced CT images. You can see artifacts from the surgical material within the liver due to a partial hepatectomy. You'll notice that scans through the lower chest show abnormal soft tissue enhancement at the level of the lower thoracic spine. So what I always try to do in every patient is evaluate the spine on sagittal images, and I like soft tissue windows to do this rather than bone windows because I think it increases the diagnostic yield of seeing abnormal epidural soft tissue. So as in this patient, you can see that there's a mild pathologic compression fracture at the level of the lower thoracic spine, and the red arrows show abnormally enhancing epidural soft tissue, which is actually indenting the spinal canal at this level and suspicion for malignant cord compression. When you see this, you really have to pick up the phone and call the referring physician to let them know that you suspect this because the patient needs to be emergently evaluated with MRI for signs of cord compression. And again, they either need to have emergency radiation or surgical decompression to relieve that. And this is a follow-up on the same patient. Again, you see the post-surgical material within the right upper quadrant from his prior partial hepatectomy. In his case, he underwent surgical decompression for the pathologic fracture and cord compression at the level of the lower thoracic spine. And subsequent CT actually shows that he has progression of disease, and in this case, a pretty large expansor bony met involving the left iliac wound with extension into the adjacent musculature. And I think that's the end of my presentation. Thank you for your attention. I hope you find this useful, and I'm happy to take any questions. Thank you.
Thank you, Dr. Fidvi, for the very comprehensive and an interesting lecture. We don't have any questions right now, but we can wait a bit and see if any questions pop up. Meanwhile, if anyone has any questions, please put it in the Q&A box and we'll get to them. We have a few messages saying that they really enjoyed the lecture. I'll start off with one question from myself. During the contrast shortage, did you see any change in your efficiency as a team to identify those oncologic emergencies and treat them?
So actually we did not, because we contracted with our use of iodinated contrast was not affected, thankfully, by the contrast shortage at all. So we didn't. What we did do was kind of limit our CT the volume that we injected. So we usually tend not to exceed more than 100 cc's unless the patient is very large, but we were able to ride the contrast shortage without compromising on our scan score. So we were lucky enough to be able to.
Yeah. We do have one question. I think they're trying to ask between about the relation between subdural cord compression and bucket lymphoma.
So I'm not a neuroradiologist, and I don't. It's something that I probably would need to look up. Perhaps, Abhinav, if you're budding neuroradiologist, I'm not sure whether you can tackle that better, but that's a little bit beyond my expertise. I know that in my practice, basically, my approach is similar to what I showed you in the case of HCC, is that I specifically look at what I look for is always making a point in my practice to evaluate the spine on statural imaging and to look specifically, because normally you always look to bone windows to evaluate the spine and adjacent soft tissues. But I think that if you use a contrast enhanced, if you use the soft tissue setting and window appropriately, your chances of seeing the abnormal epidural soft tissue are much, much higher. I don't know how you can differentiate, I don't know what it was, epidural tissue versus lymphoma on CT.
The question is not clear, to be honest. It just says bucket lymphoma and subdural cord compression ? So
I'm sorry, that's a little beyond my.
Yeah. There's one more question. What courses do you suggest for learning abdominal radiology for someone who's just starting out?
It's a great question. I think that one of the challenges in current environment is actually the amount of information that's available now, because it's kind of difficult to cull through everything that's available and find something that's useful. There's actually some great websites that are available for teaching, particularly that I use for medical students and so forth. One is Abdominal Radiology is Us, which actually gives you a lot of examples of different kinds of pathology and associated imaging. Another that I like, which has a lot of good examples, is CT is Us from Johns Hopkins, which is a great cache of information for everything in abdominal radiology. So.
And we have a YouTube channel as well where we upload all of these lectures. So
yes, I discovered that recently. So that's also an excellent resource. I think anyone looking to learn could definitely benefit from reviewing those. So.
And then we had one more question just pop up. What do you suggest in differentiation of mesenteric deposit with desmoplastic changes compared to post-treatment enteritis?
I'm sorry, could you repeat the question?
I think that they're trying to ask how would you differentiate mesenteric deposit with desmoplastic changes compared to post-treatment enteritis?
So post-treatment enteritis actually involves the wall of the bowel itself. Okay, so you're looking for, obviously these history is important. So the patient would, you need to know that the patient has a history of a cancer, which is treated with radiation. Like I showed you, a lot of cases of radiation specifically involve the pelvis because the vast majority of tumors in the pelvis are treated with radiation. So if you see bowel wall thickening that's specifically localized to that area, you also look for changes like in the presacral space. One of the other things that I also like to use on CT is if you look at a sagittal image of the spine on CT, sometimes you can see that the marrow in the spine is replaced by fat. It just looks fatty compared to the rest of the spine, and you know that the patient has received localized radiation in that area. So if you see bowel wall thickening in that vicinity, it's probably related to radiation enteritis, whereas mesenteric disease actually involves predominantly the mesentery. So you would see in the case of mesenteric malignant disease, you'd see mass-like thickening and enhancement involving the mesentery, and could cause a secondary fibroblastic reaction and kind of tether the bowel. A typical example would be like a tumor like carcinoid. I hope that answers the question.
We just had one more question pop up. So do you think there is any way to prevent these complications? They say that would annual CT scan probably help us find these pathologies and prevent them?
I don't know if there's a way to prevent them. I mean, the fact of the matter is that, I mean, in our practice, as I'm sure it's probably true of a lot of practices, is that both through the emergency room and in our routine practice, I've just seen an increased incidence of cancers that present, de novo through the emergency room. So patients will have pain for whatever reason they're scanned, and it turns out that they have metastatic disease or some form of cancer that is causing obstruction. And I think it's really important just to be aware of the presentation and then the spectrum of complications that you can see on an emergent basis, or even if you're routinely reading, if you have a long CT list and you're doing like oncology follow-up, it's really important to be able to recognize these complications and to then alert your referring clinician to say that, this is different from the patient's routine cancer, and this constitutes like some kind of urgent intervention. So you can be that person that actually raises that flag and brings it to the attention of the referring clinicians. I think, as a radiologist, it just behooves us to be aware of the multitude of complications that can occur, especially in this era of IREs, immune-related adverse events, to know the different kinds of complications that can occur and to recognize them and let our referring clinicians know.
I think that concludes our questions, and we don't have any more questions. So I think that concludes our grand rounds for this week. Thank you, Dr. Fidvi, for taking the time out of your schedule to be here. We're very grateful.
Thank you, Abhinav, and thank you for moderating the session. And I certainly hope that this has been of value to everyone who's listening.
Thank you so much.